Okay, this is week 13, upper extremity, getting into tendon injuries, flexor tendon injuries, and extensor tendon injuries. This is kind of more intense, involved hand therapy. You see these kinds of injuries in general outpatient, but a lot of times it's a CHT, a hand therapist, or somebody with the skills of a hand therapist that's dealing with these kinds of surgeries, right off, working with an orthopedic surgeon regularly. They can get quite involved. On one level, they seem kind of basic. At another level, they get very complicated very quick. So we're talking about serious lacerations to the hand. Box cutter lacerations, saw lacerations, all kinds of awful lacerations to the palm or dorsal side of the hand. Here's our objectives for today. There's our case. This is one of Andrew Sumberger's, the CHT at Northern Light, one of our real cases. This young woman, 27, zone 2. We'll talk about zone 2 in a second. She had a FDS, Flexor digitorum superficialis repair of the right index finger and long fingers. She was helping her grandmother change a light bulb in her dining room when attempting to unscrew the bulb from the light fixture. The bulb shattered and the glass shards lacerated her FDS and the right index finger and the long fingers. So the question is, what kind of splint do we make for her? What kind of instructions do we give her? What kind of exercise protocol do we give her? And she's in zone 2, which is called no man's land in the hand. Kind of what is that? Why is it no man's hand? Okay, let's just keep going back to that anatomy. Going to keep that in mind as we kind of do these. Here's the two big flexors, as you know, the profundus, which goes all the way out, and then the FDS, which goes out to the PIP. These all big flexors of the hand. Again, keep in mind that the flexors all work together. They're the big muscle belly. It's all connected to the big muscle belly up on the interior forearm. So we have to kind of think about splinting them all together because it's very hard to isolate one of them, as we talked about with the shearing or the metacarpals and that sort of stuff. There's also flexors in the hand from the thumb, the flexor pollicis brevis and the flexor pollicis longus, flexing the MP and IP of the thumb. The lumbricals and dorsi deep in the hand. It gets really complicated when you start lacerating them. They also play a role with flexion and extension and ab and adduction, as you know. Let's kind of talk about a little bit how these tendons are kind of built in the hand. They're covered by like a sheath. So it's kind of like the tendon slides through a straw. It's almost like a string pulling through a straw. So it kind of goes back and forth. The sheaths keep the tendon gliding in the right direction and provide a degree of protection. These sheaths frequently get, again, think of them as the straw, frequently get nicked and damaged with hand laceration of injuries or phalangeal digit fractures, causing scarring and resulting limitations in tendon excursion and range of motion. We talked a little bit about that last week with that extensor lag with the scarring on the EDC in the backside. These sheaths, again, it's a tight space. We keep going back to that theme of space and flow. In this case, it's space and range of motion. The adhesions, the scarring limit that range of motion, cause all kinds of contractures and issues with the hand. So kind of think of it, that scarring and adhesion kind of builds up. And it usually builds up if we're not getting that range of motion in there as soon as we can. The range of motion, the excursion of the tendon limits that kind of buildup of scarring or kind of stuff within there. Kind of think of it as trying to pull a string through a straw with too much stuff or scarring in it. You can't get the string to go where you want it to go. So we have to get it moving, work on that scar adhesions, right off the bat. That's kind of our job as therapists. Here's the sheaths, kind of the straws, like I said. You see there's the tendon, just kind of glides up and down through the sheaths. Then we have these pulleys. What are the pulleys? These on the palm of the hand. There's a series of pulleys in each digit. Think of them kind of like the eyelets or the little metal circles in a fishing rod. And the line travels through those little eyelets, those little metal circles in a fishing rod, like this. These are like the pulleys. They kind of hold the tendons or the fishing line in place, and they help with excursion as you cast and reel in the line. So they play a crucial role in making efficient gliding or range of motion of the digit, flexion of the digit. Pulleys keep the tensions close to the bone, maximize what they call excursion, or that range of motion. Without the pulley system, like if one of them gets torn or ripped, damaged when they cut their hand, the tendon's bowstring, diminishing range of motion and strength. They have to be kind of repaired. So think of this, say this is one of the pulleys, and it breaks, it gets torn. So it's going to come out like this. I mean, you're still going to be able to reel in a fish, but it's going to be kind of like all over the place and very inefficient. There are two types of pulleys. There's the annular ligaments, they're kind of like bands. And then there's the cruciate ligaments. The annular are just designated as A, the cruciate ligaments are just designated as C. The cruciate ligaments are like crisscross. Some of the pulleys are a lot more crucial than others. The A2 pulley is probably the most crucial to prevent bowstringing. If you tear that A2 pulley, you're going to have inefficient flexion, excursion of the digits. It's going to impact your function. The A1 pulley, as has been said in class, is really involved with trigger finger. So that gets scarring, swelling through that pulley. It's going to help start making it snap and catch and hard to extend. Here's the pulleys. See the A2? See how big it is? This is the big one. Don't want to tear that one. That will really impact your ability to glide the tendon back and forth. Here's the A1. You can visualize that. That's in the palm of the hand. That's the one that's involved with trigger finger. There's the C ones. Cruciates, the other, they're bands, and there's the smaller pulleys. Here's kind of a anatomy view of these. These are hard to get in anatomy. I don't think you saw these with your cadavers. But here's the pulleys. Here's the A1. So there's right palm of the hand coming up. Here's the A2, the real big one. There's the FDP, the flexor profundus, gliding through the pulley. See how it's kind of tight? The pulley's tight up against the tendon and the sheath, giving that good excursion. If that's torn, it's going to kind of come out some, what they call bowstringing. And it'll be inefficient, hard to flex the finger as well. There's the A2 again, there's the A3. See the band, the crossing band of the C1 pulley. There's also like zones of the hand, and you need to know these when you get like protocols from the doctor in terms of what zone it is and splinting and that sort of stuff. Kind of hand therapy terminology. These are for the flexor tendons, classified for their different structures. This is the zone 2 we were talking about. Why is that called no man's land? There's just a lot of stuff in there in terms of tendons, sheaths, pulleys, fascia, really prone to scarring, quick scarring formation. You cut it in here, you can really scar it up quickly. What does scarring mean? Contractures, limits range of motion. So it kind of pulls into like a flexion kind of thing, and you can't use your hand. It gets kind of stuck. They used to avoid surgery in here because of all that stuff in there, and they get those quick adhesions. So we just can't go there. You're kind of out of luck. It's different now. They go right in there. They're very efficient at it. But before, historically, they had really poor outcomes with anything in zone 2. Not the case so much anymore. Generally speaking, tendon injuries are usually obvious. They have surgery. They come to you with a protocol, and the orthopedic surgeon will tell you exactly what he wants you to do. Sometimes, though, people cut their flexor tendon or damage it, and they don't go to the doctor. They don't really know what's going on, and they come to you. It's just my finger doesn't work right. The MD may not be familiar with flexor tendon injuries. How do you kind of test for that? It's pretty simple, as you would think. If you're worried about the profundus, just immobilize the PIP and flex the DIP. If you're worried about the FDS, you have to kind of mobilize the other digits. So again, make that thing where they all kind of work together. Mobilize, let's say it's that second digit you're worried about, so you mobilize the third, fourth, and fifth, and flex the second, and if they can bend that PIP, or they can't bend that PIP, it would be an injury. If they can, they're good. Here's a good little video to kind of shows you how to kind of assess these tendon injuries, kind of thing, with these different simple kind of tests. Tendon repair healing time. This is crucial as a therapist. Because you're kind of thinking, I want to get that range of motion in there as soon as I can, get this person doing their functional things they want to be able to do again. When can I do that? If you know the healing principles, you're kind of ahead of the game. You kind of, as your skill as a clinician kind of grows. At first, I would imagine you're going to be kind of stuck on those protocols, doing exactly what the doc wants and kind of communicating a lot. But once you get better at it, you can kind of sense things when you start to do whatever you start to do, and you're kind of communicating, and you're not tied so strictly to that protocol. So really it comes down to knowing how things heal, knowing how these tendons kind of repair. What the surgeon does, I'm actually going to see this in a second, but you'll see this on the video if you play it. They kind of tie or suture or string the two ends of the tendon together. So they've been cut in half. They kind of retract and they're free floating, and they pull them together and they tie them together. Once it's repaired, the body begins by kind of dissolving the ends and then kind of growing them back together again. Day 10, this is key. The repair is at its weakest point. Don't want to be doing all kinds of range of motion and pushing it at day 10. Day 21, they're stronger. They're kind of knitted back together. You can start maybe a little bit more aggressive kind of stuff. And this is a nasty little tendon repair through the like zigzag formation they classically use. Here's the repair. There's the string that they're using, the 4-string repair, which is common now. So they're cutting it open and going after it. It's a great little video. Check that out. As you're doing this, again, it's really a balancing act between getting as much active and passive range of motion as you can without pushing it too much. It's all good, the range of motion, passive range of motion, to a degree, but you kind of run the risk of rupturing it. So you really have to get a clinical sense when you do this a zillion times. Again, you're relying on the surgeon and the protocol initially to get more and more comfortable with this. Active gliding immediately after surgery reduces the likelihood of adhesions. We don't want that. Adhesions lead to these chronic long-term problems where they don't have the motion they need to do what they want to be able to do. But again, it risks rupturing the tendon. The tensile strength is not strong enough. So it's kind of a balancing act. This is us doing the force, the range of motion. And these are the principles we have to kind of think about as we're judging how much force to kind of play into this, around wound healing, scar formation, strength of the repair, constant communication with the surgeon around these kinds of issues, variables. All flexor tendon repairs, regardless of injury, are treated the same kind of protocol with slight variation. Same kind of splint that you're going to make, that dorsal blocking splint we saw last week. That's the splint for all these flexor tendon repairs. Watch for nerve issues. A lot of times they're nicking that median nerve or some other nerves, ulnar nerve, along with the tendons because if there's a nasty kind of cut. 12 to 14 weeks. Sounds kind of familiar, doesn't it? That's kind of where there's enough strength to kind of resume normal activities, unrestricted activities. Again, these are just general protocols. You're talking to the physician, they all have different ideas of when to do what, that sort of thing, and depending on those variables around healing. Most repairs are now 4-strand, also more gliding without rupture. It makes it a little stronger so you can get a little more aggressive early on. A new kind of surgery they're doing, this wallant. I don't think there's a lot main from what Andrea was telling me, at least not up this way. They're doing it when the person's wide awake, local anesthetic, and they can kind of have them move their hand and kind of see how it's doing as they're doing the surgery. Drastically reduces the risk of rupture, and improves outcomes. 3 basic types of rehab: early active range of motion, early passive range of motion, and in some cases they're immobilizing it. A child that's going to be pulling and doing all kinds of nasty things to it, you may have to kind of cast it, immobilize it. An unreliable patient, somebody with mental health issues, dementia, you may have to cast them. They're not going to get the same outcome. They're going to get more contractures and stiffness, but you got to do what you got to do to repair those tendons. Okay, so there's different kinds of protocols, different kinds of approaches. This is stuff that's very popular for board exam questions. The Klein heart, it's important to know historically, they don't really follow this strict protocol so much anymore, but a lot of the concepts around it, principles, are still followed. This dorsal blocking splints, he really got into this idea of passive as active system range of motion early on in the whole process to kind of reduce the adhesions to get better outcomes. So that's what's really his really big contribution, along with this dorsal blocking splint. They've kind of varied the degree of flexion with the MPs in this. Talk about this in the lab. This is the dynamic component they don't use so much anymore. Some surgeons may use it. It takes a lot of compliance in terms of the patient. They glue these on. They use little bands to hold them on. They come off very easily. What it does is that it provides an active passive range of motion. So what the person does is they actively extend their digits within the limitations of the blocking splint. It forces them or keeps them from extending their fingers too much, because we visualize the hand kind of in that intrinsic plus MCP flexion position. If you extended those digits all the way, just feel the stress on the palm side of your hand of all those flexors. So you'd put too much stress on the flexors and you'd rip them, you'd rupture them. So the blocking splint keeps you from doing that. It's like a safety position. You can't extend too far. But on the other side, it allows you to kind of do some motion within those limitations of the splint. So what you're doing is, with this Klein heart, the band pushes you into passive flexion, and then you actively extend against the band within the limitations of the splint. So you're getting passive range of motion and active range of motion, fighting those adhesions right off the bat. The safety position we talked about gives you some glide of the FDS, FTP, and he figured out pretty quickly that it's better to get these MCPs in flexion versus the straight carotid chop. People will be coming out of that surgery with that carotid chop, and they would never get their functional fist back again. So he wants to get them into that flexion. Just seems to heal quicker that way. There's elastic traction. This has kind of been modified. This is kind of one of the more popular ones. The Durand Hauser, what did they do? Got rid of the bands, and they just have the person passively flex their digits and actively extend against the limitations of the splint. So they're passively flexing and actively extending. You need compliance with the patient. This is a big part of it is education, getting the patient on board, because if they start doing what they're not supposed to be doing, they can run into trouble quickly and end up having to go back and repairing those ruptures. But ideally, they're doing what you ask them to do. They're doing this constantly to kind of fight those adhesions. Another kind of variation on it is this Strickland Indiana protocol. They do the wrist tenodesis. Gives you a little bit more motion at the wrist. When they do the exercises, gives them a little more flexion. They kind of do this tenodesis where they come down, flex, and kind of come up kind of thing. Bottom line is most therapists and surgeons who kind of drive these protocols kind of pick and choose. They kind of do combinations of different ones. Depends on their preference, depends on what they've had historically for good outcomes kind of thing. So you have to kind of know what they want you to do kind of thing. And then the clinical judgment comes in, and you may think, like, I want to go try this or that with this patient, kind of varying from the protocol, talking to the surgeon about your ideas, and you get more and more skilled at this. General guidelines for tendon repair protocol. Usually you see them around day 4. They come in, they're kind of a bloody mess. Post-surgery, they're kind of wrapped up in some kind of crude splint. You're going to make them that dorsal blocking splint. Remember that it's weak, day 10, day 21 it's strongest. They're in that splint usually for at least 6 weeks, that safety position, doing those exercises that we talked about. Getting that MPs into flexion and kind of balancing protection with motion kind of thing. Okay, now we're moving on to the extensors. This is for the extensor tendon injuries, lacerations to the back side of your hand, generally speaking. The big extensors, as we know, the EDC, again, that one muscle belly, all those tendons. You can consider that when we're splinting. And then the extensor indices for the pointer finger, and then extensor digiti minimi for the pinky. We also have extensors on the thumb as well, for the extensor pollicis brevis and extensor pollicis longus. Come way up the forearm with the longus, as well as the lumbricals the lumbricals. I mean, lumbricals and interossei are very complicated. This is kind of we talk about these layers of anatomy. You really have to kind of get into this if we're getting into hand therapy. They can kind of do both, flexing and extensing. So that's what gets difficult. Extensor tendon anatomy. The anatomy is a little bit different. They have the sheaths as well. They also have these compartments. They're called these dorsal compartments. So they have the sheaths, the straw, where the string kind of glides through the straw. They have that. And they have these compartments, kind of separate the extensors into kind of different groups. So every time you hear the word compartment, your ears pick up, oh, compartment, potential problem. The compartment for the carpal tunnel, think of that. All that tight space for the PTS. But when you have the compartment, there's a possibility of space and flow issues. That space, get adhesions in those compartments, limitations of gliding. So kind of be aware of that compartment kind of syndrome kind of thing. Here are the different compartments. There's the 6 of them. See how they group some of these extensors together? Here's the EDC kind of grouping. This compartment 1, which is on the side of your thumb there, this is a common issue for the decar veins that we talked about. The abductor pollicis longus and the extensor pollicis brevis. These commonly get very irritated, repeated thumb movements, pushes up against the sheath, pushes up against the compartment. Get a space and flow issue, irritation, pain, all that sort of stuff. There's another view of the compartments. Here's compartment 1. Again, tight spaces that they're gliding through there. That reminds you what the carpal tunnel looks like. Same kind of concept. All right, so we have these compartments with extensors and the sheaths. We also have these zones. Just like the flexors, we have the zones, different kinds of zones. And with these zones, they kind of break up the joints of the fingers. And they're quite different splints depending on the zone and the suture and the structures involved. And there's protocols for each zone that is different. So it's a different splint, different protocol for each zone. Flexor tendon repairs are much easier. It's just that one splint, the dorsal blocking splint, and the similar protocols. Here we're talking different depending on the zone of the injury. Here are the zones, and here are the splints. We've done some of these, like with the mallet, the DIP, and the boots, acute boutonniere kind of thing. Talking PIP 4 and 5, getting more into the metacarpals kind of area. We're talking about worries about shearing, getting those adjacent fingers. This is crush injury. That's a dynamic splint, much more involved. And then 5 and 6 and 7 and 8. And here they all are. Here's the 2 we're kind of familiar with. Just getting those guys into extension, the DIP and the PIPs there. This is the one for the crush injury. Very complicated, involved splint. It's dynamic. There's that traction component, like the Klein protocol. And here's the other ones for the 7 and 8, 5 and 6, and then 4 and 5 here. So these are going to good to know, good reference. Again, so you're out in the clinic, your CI starts talking about what kind of splint are we going to do for this extensor tendon injury. You're not going to know how to do the splint or the particulars of it, but you have a ballpark. Oh, that sounds like a zone 5 and 6. Let's do this kind of splint, kind of thing. Really, the goal here with a lot of this stuff is just to make that transition to the clinic, to your fieldwork, so much smoother, so much easier, being totally blind. It kind of gives you a framework, the way I look at it. And you're going to get all the filling, all the details with your CI and on the job, or at least you have that framework to start kind of building and putting in all the parts. Learning objectives. Let's go back to those. Why do the surgeons previously avoid no man's land in the hand? That's zone 2. And there's just so much there in terms of tendons, sheaths, and fascia. very prone to scarring, very poor outcomes initially. They're better at that, but that's kind of why they can avoid it. What is the purpose of the pulley system in the hand? Those pulleys, especially the A2 pulley, it maximizes excursion, maximizes motion or efficient movement of the digits. What kind of balance needs to be struck for proper rehab of flexor tendon repair? You're balancing range of motion with healing. The range of motion facilitates the healing. You don't want to do too aggressive because you can cause a rupture. You're kind of pushing it as much as you can within the parameters of the healing and the protocol, that sort of thing. What is the big difference between the Klein and the Durand protocols? Klein has the bands. Durand does not. So remember, Klein, they're both kind of in the dorsal blocking splint, different degrees of motion, but they're basically both kind of dorsal blocking splints. The Klein has those bands pushing them into passive range of motion, and they actively extend against the band. With the Durand, they're kind of the patient's doing themselves. They're passively flexing their digit and actively extending against the limitations of the splint. How do you generally rehab the hand following a flexor tendon repair? First thing you're doing, they're coming in, you're checking the wound, putting them into a dorsal blocking splint. That's kind of your big first thing. And then you're starting getting into that protocol, what we talked about, passive flexion, active extension within the limitations of within the splint. How do you test for the integrity Fds Ftp? Let's do the FTP first. That's the tip. So the FTP, the flexor digitorum profundus, flexes the DIP joint of the digit. So if we isolate the PIP, the MCP, and just see, can they bend the tip of their finger? If they can't, might be something going on with that profundus. Maybe been lacerated, maybe damaged. Send them off to a surgeon. Need to get that repair. FDS, flexor digitorum superficialis. How do we assess that one? So we hold back let's say it's the second digit, hold back all the other digits, flex that PIP. That's what the superficialis, the FDS does. If they can flex it, they're good. If they can't, maybe the FDS. That's the issues there. This is kind of a quick and dirty lecture review. The tendon injuries, talking about the balance kind of thing, gives you some protocols, what you're doing right off the bat, making the splints. Again, edema, we talked about that. Passive digiflexion and active extension. And then you're kind of beginning protective active range of motion. And then light ADLs and kind of strengthening kind of thing. Okay, so this lady who cuts her FDS with a broken bulb there, what kind of splint would you make her? She would be a classic dorsal blocking splint. What kind of instructions would you give her? Keep that splint on, no active extension. If you extend your hand, outside the limitations of that splint, you're going to rupture all the nice work that the surgeon did. Exercises, passive flexion, active extension within the limitations of the splint. No man's land, zone 2. DOE, most of you have that done, that's do 12-7, and then the hand construction is do 12-7 as well.